Okay, so what happens when the body's metabolism just completely goes into a tailspin? Well, you can end up in a state called diabetic ketoacidosis, or DKA. And let me tell you, managing it isn't just a simple treatment. It's a high-stakes, full-on rescue mission. So today we're going to dive deep into the protocol and see exactly how clinicians pull the body back from the brink. Our rescue mission is going to unfold in 6 critical phases. First, we've got to understand the emergency itself. Then we'll launch our first response with fluids, followed by the absolutely essential insulin intervention. After that, it gets tricky with a delicate potassium balancing act. From there, it's all about constant monitoring to guide the patient to safety. And finally, we'll wrap up with the key goals of our mission. So what in the world is DKA? Well, it's a really dangerous situation where a lack of insulin causes 2 major things to happen at once. First, blood sugar skyrockets. Second, the body gets desperate for fuel, so it starts burning fat like crazy, which produces high levels of acids called ketones. This combination creates this toxic, dehydrated, and super acidic environment in the body. The stakes really couldn't be higher. I want you to picture this scene. A patient comes into the ER and they're showing all the signs of DKA. The clock is ticking, you know? But before you can do anything, you have to assess the situation. So what's the very first move you make?
It all starts right here with what is basically a rapid-fire data grab. You check the basics first, the ABCs: airway, breathing, circulation. Are they stable? Then you get vitals and check their mental status. At the exact same time, you need a snapshot of the chaos happening inside. That means checking blood sugar, getting blood gases to see just how acidic things are, checking electrolytes, kidney function, and of course, confirming the presence of those ketones.
All right, with that initial assessment done, the first active step in our rescue mission can begin. And it's probably not what you think. It's not insulin, it's fluids. Rehydration is the absolute foundation for getting the patient stable.
And listen, this isn't just about pouring in water, this is about precision. You can see we start really aggressively in that first hour with normal saline to get their fluid volume back up fast. Then we ease back on the rate, and we might even switch to what's called half normal saline. This whole careful progression rehydrates the body gradually, which is so important for preventing sudden fluid shifts that could be really dangerous, especially for the brain. Okay, the patient's getting rehydrated. Now it's time to bring in the big gun, insulin. Insulin is the key. It literally unlocks the cells so they can take in all that excess glucose. This does 2 things. It stops the body from making those dangerous ketones, and it starts bringing that super high blood sugar down.
So we use a continuous IV drip of regular insulin. But look at that goal. This is so important. We are not trying to just slam the blood sugar down to normal. We're aiming for a slow, controlled drop of about 50 to 75 milligrams per deciliter per hour. Why? Because dropping it too fast can cause its own set of life-threatening problems, like dangerous swelling in the brain. We have to be careful. Now, this next step, it might seem completely backwards, but it's one of the most brilliant parts of the entire protocol. Once the glucose level gets down below 250, we actually start adding sugar, dextrose, to the IV fluids. You're probably thinking, why would we do that? Well, it's because our main goal has shifted. We still need that insulin running to stop the ketone production, but now we also have to prevent their blood sugar from crashing while we finish correcting that acid-base imbalance. It's a really clever pivot. So we're managing fluids, we're controlling glucose with insulin. It really seems like we're on the right track, doesn't it? But here's the thing. Insulin is only half the story. It actually creates another kind of hidden danger that we have to manage at the exact same time. And that brings us to the potassium balancing act. You see, as insulin pushes all that sugar into the cells, it takes potassium along with it for the ride. This can cause the potassium levels in the blood to just plummet, which is a condition called hypokalemia. And that is super dangerous. It can lead to fatal heart arrhythmias. Because of that risk, we have to follow this strict rulebook. If potassium is high, we just wait and watch. If it's in the normal range, we start proactively adding potassium to the IV fluids to stay ahead of the drop. But here is the most critical rule of all. If the potassium is already low, we're talking less than 3.5, you must hold the insulin. You stop and you give potassium first. Starting insulin at that point would be incredibly dangerous. So with fluids, insulin, and potassium all being managed, the acute crisis is finally getting under control. But the mission is not over yet, not by a long shot. Now it's all about constant monitoring to navigate the patient safely to a full resolution. Now, we mentioned how acidic the body gets. Just how bad does it have to be to need extra help? Well, very rarely, if the body's pH drops below this critical level of 6.9, a bicarbonate infusion might be considered. It basically acts like a buffer to help neutralize that severe acid buildup, but this is an intervention that's reserved only for the absolute most extreme cases. This whole phase is really about vigilance. We're checking blood glucose every single hour. We're rechecking electrolytes and blood gases every 2 to 4 hours. We are tracking every single drop of fluid that goes in and comes out. This constant stream of data is what lets us make real-time adjustments to the whole rescue plan. So when do we know the patient is finally out of the woods? Not until they hit every single one of these targets. They have to be able to eat, and their blood work has to prove that the acidosis is gone. Only then can we even think about starting their regular under-the-skin insulin. And check out step 6. There is a crucial 1 to 2 hour overlap. This makes sure there's no gap in insulin coverage, which could literally send them right back into DKA. Whew, so we've walked through the entire rescue. Now let's just zoom out for a second and look at the big picture. What were the ultimate mission objectives of this whole protocol? There are 4 main ones. First, we had to correct that profound dehydration. Second, we had to reverse the acidosis and stop the ketone production. Third, we needed to bring glucose levels back to normal, but slowly and safely. And fourth, we had to replenish and rebalance all those critical electrolytes, especially potassium. You achieve all 4 of those, and that right there is mission accomplished. At the end of the day, we have this incredibly effective protocol. It's like a map that guides the way, but it's so important to remember that every single patient is different. Their response, their other health conditions, their unique needs, it all plays a part. Which really leaves us with this final thought. The protocol is the map, but a clinician's true skill lies in navigating that patient's own individual journey back to health.